Place your name and campus in the chat. Go ahead and get yourselves in position. We have about 30 more seconds to officially start. All right, we're going to call it official start time. All right, go ahead and place your name in the chat. Good evening to everyone. Go ahead and place your name and your campus in the chat. Check your screen name, ensure that it matches. Your name and your campus in the chat. If you're needing to change your screen name, just let me know. I can talk you through that. As always, these sessions are recorded and they can be viewed by the attendance administrators. In the event that you're experiencing any connectivity issue, please, or any issue, please just put a message in the chat to me so that we can have documentation of what's going on and hopefully come up with a solution. So good evening to everyone. I'm giving you all a few more seconds to place your name and campus in the chat. Good to see everyone. If you just placed your name, please go back and put your campus as well. Thank you. All right, we are here. We are in week 8. I told you it's gonna go by fast. After you take it, seems like every time it's the same time, but it just seems like once you take that first exam, that time moves. So again, I advise you to refocus, look at your schedules, everything, consider all that you have, um, that you're responsible for. Consider all of that. Okay. So I will timer there. Again, put things on pause that you can pause, delete things that you need to delete, rearrange however it works for you. Just making sure that you're being proactive with your time and all of your responsibilities here. All right, so we are in week 8. Of course, we do have some required readings. You do have another lesson and another quiz. And then next week, we have unit exam 3. In the event that you think you don't need that exam proctored on campus, please send an email to your campus dean. Get permission. All campuses do not allow this to take place, or it can't take place. However, it does. Please communicate with your campus deans. They have to approve it. The person that will proctor you, it has to be approved by your campus dean. Place all of that information, including the day and time, in an email so that I can have that information and we can move forward with that. It does require at least a 72-hour notice. And then week 10, we hear from you all, and then we'll do some HESI review. Week 11, all HESIs are this week. Generally, like I said, week 1, generally week 11. Usually HESIs are not given this time, so just make note that your week 11 will look different from the rest of your term. A Friday class might be HESI might be on a Monday because these things, your HESIs are campus specific. So for sure, by the end of week 9, beginning of 10, you should be getting information from your campus deans on what, when, and where, and the time and all of that for your HESI. So again, go back to week 1, start looking at all of the concepts. Just making sure that you have that strong foundational knowledge about all the concepts. Let's go back through your required readings, the recordings, and all of that for that HESI. And then week 12, we do meet briefly. You will receive an email to your Outlook mail that comes from Education Affiliates that is a survey that we're asking you all to complete. In the event that there are questions that do not apply to you, just make sure you make a note on there. I think you can actually type in some information, question 12, 13, whatever does not apply to me, but please complete that. And we do look at our rates, our scores, and all of that, but we don't meet that long on week 12. Now, in the past, I don't know how to follow this term, If you have a Friday, Thursday, even a Wednesday class, your week 12 might look a little different as well, but you will get instructions from your professor. Ours won't because we meet on Tuesday. So it's usually that Wednesday, Thursday, and Friday class is where we had to adjust things. So, but you'll get information on that. But just kind of to let you know where we're going and where we're headed here. So let's go back up here. So we have an exam next week. It does cover everything for week 7. You know, how are we paying for our health care? You know, we're providing this best care for our patients, no matter what the setting, no matter their pay status, no matter what environment community they come from. You know, how are these things being paid for? And then we are going to look at 2 of your theories. I think we have Anderson, and I can't call the other one right off. But there are numerous theories, but we're going to particularly look at 2. And you're going to be looking at theories throughout your career because facilities, they actually let those theories guide what they, how their policies and procedures are in their facility, along with the Nurse State Practice Act and all those other healthcare workers that's in their facility as well. And then so 2 works of content will be on this unit exam. All right. Are any questions before we get started here? We're gonna try to toggle back. We're gonna make sure that we cover everything. We're gonna do just a small group activity just to get our up and running, and then we're gonna make sure we cover everything. So it should be repetitive. When you hear certain things, like, oh, I know what that is. I've heard that 10 times. I heard that 7 times, and you should know what it is, no matter how. And that's gonna be good because no matter how you're asked that question, NCLEX, HESI, you're gonna know how to pick the correct answer because you have that strong foundational knowledge. Are there any questions? And so, yes, let me know in the chat if you're having to step away from the camera. Therefore, if they're asking about, why you're not on camera or something, just we have documentation that says what's happening. If you have a background up, and make sure that you're on camera, physically, not just your background showing you. I wouldn't like for you to be marked absent because the only thing we saw that day was your background, with a picture of you that you were not actually there. So again, just letting you know these recordings are viewed by the attendance administrators. Your attendance is important. All right, so let me see here what we got. We have 5. We're going to start off with 5 slides to mix it up, and then I want to make sure we go back and cover everything. So we are ready to go for NCLEX, HESI, and exam 3. So we have Nurse Bill and Nurse Melissa here. They're going to be talking. Let's do our first part of our lesson today. So they are talking about several concepts here. I'm going to send this to your mail. I'm just going to copy this right here and paste it into your Canvas mail. And what we're going to do is give you all about 8 minutes to complete it. So again, I am checking for a message in the chat if you are not on camera. Again, your background, a picture of you does not count as being on camera. In the event that you have to be away from camera, you need to put a message in the chat so that we'll know what you're doing. Won't you just make an informed decision? All right, so we're gonna put you in brief groups. It's not your group that you're gonna be presenting from. It's just a group just to talk about these concepts here. And I'm gonna send it to your Canvas mail because most of you all have your Canvas open. And we'll give you a little time to talk it through. Ooh, when I pasted it there, it did a whole bunch of little things. So let me just put the slide in the Canvas. Because when I just copied the information from the yeah, I'm just gonna put it in there. Because what it did when I copied it, it um, just like pushed it all together. It's not any dashes or anything in it. So it's jumbled up. So I'm going to place this slide in your, and it's just one slide that says Nurse Bill and Nurse Melissa. I didn't see any questions regarding, the content. But nevertheless, we're going to go back over everything before we finish tonight anyway. So we're going to go back and look at it. It's not there yet, you all. It's not there yet. Waiting on the attachment to load. Wait, trying to get it to you all. Okay, it's trying to load you. All right, and it's just going to say activity, and it is being sent now. Go ahead and open the breakout room. Did it, did it. Let's see, breakout rooms are right there. Okay, so the instructions are open your Canvas mail. There is an activity there. There's one slide. It says activity. I just sent it. It's in your Canvas mail. Going to give you 8 minutes to review it, and then you're going to come back and we're going to hear from everybody. So accept the invitation to go to the breakout room. And so as you're looking and discussing those topics, make it, in easy to understand terms, paraphrase it and all of that. 8 minutes. Let me set my timer. All right, accept the invitation. Go on over to the breakout room. Miss Alexander, are you having connectivity issues? It look like you might be having some connectivity issues. Miss Lampy, did you get the message to go to the breakout room? Okay. All righty, everyone should be back in about 45 seconds. Okay, 20 seconds. We should all be back and we will hear from you. All righty, I think we have everyone back. Okay, so let's go ahead and let me share my screen here and we'll hear from you. Share.
Recording in progress.
Okay. So safety. So we have nurse. The two nurses are talking. So talk to us about safety, and that's Senior and Carter. So Nurse Bill and Nurse Melissa are discussing the following. It says discuss each and list two findings from each for each. So Carter and Senor, if you would tell us about safety.
Um, Prevent medication errors, safety, prevent falls, um, infection prevention.
Verify the correct patient, medication dose, route, and time before administering medications. Um, I would say also with safety, you're trying to prevent harm to the healthcare workers as well, like the staff, especially because some people can get violent or just aggressive. And yeah,
Okay.
Follow infection control practice and patient identification.
All right. So while we're thinking inside of the workplace, don't forget, you have to leave out of that building or that place and go to your car and leave the premises. So think about safety as well as you're walking. Because most places have designated parking for the employees. And most of the
Mm-hmm.
time, it is not like, right up close and personal. It's usually out or kind of out of the way because they want to leave the up close parking for their customers, as they're paying customers, as some of them say. So be thinking about that as well as you're traveling to your vehicle, as you're walking to your vehicle. So think about how you assemble your bags, and your name tag, your keys, and all of those things, especially if the facility doesn't have an after hours um,
Security.
escort or security. And a lot of them don't. After that dusk, the dawn, it's just like you're on your own. A lot of facilities, they have this locking door. Some of them have it automatic. Some of them don't. The person that locks the door is you, the nurse. So make sure that you're following those procedures because you want to keep yourself safe as well as the patients. And you just never know when someone will, toggle in and, just be in that space. I don't know if you all heard about the nurse from Alabama walking from outside on the phone with her spouse. She's no longer with us. A person was out there just walking. And so safety, all of these things are very important. Okay, so let's go back.
Especially when they terminate some persons from the job. Person will, come back and harm people from the
Exactly.
job. Depends
Don't
on the
consider everything. We hope not, but just consider everything. Thank you all. Okay, here we go. Okay, so core measures, Lampkin, Shook, and Hunt. Core measures. So again, discuss what it is and give us two findings about what that really is, like some examples.
So core measures is more so like, I guess, not necessarily documenting, but kind of like
It's like
documenting.
specific standards
It's
used to
like
measure
document.
the quality of patient care.
Yeah. Like you would let them know, like, documentation as far as like showing that, oh, I gave this medication at a certain time or upon arrival and things like that, or what process did you do when a patient was admitted, like, okay, we know we did cultures first and they did this, say if they came in for sepsis, you would just, it's more so like documenting and follow up exactly what you did for a patient, just to make sure everything's done right.
Okay. Anything else?
Alex, you got anything else?
Yeah, it's exactly what you said. Like basically that it's like, did the healthcare team provide the care that should have been provided? And
Yeah, or
then
like follow the steps in order.
um and it core measures they help hospitals monitor and improve patient outcomes.
So how are they monitoring that call? That comes from your what?
Say that again, I'm sorry.
How are they
Right.
monitoring that? You said they monitor your last statement. You said they make sure that they're providing the best care. How
Oh,
does
that's
that
like if they go, if we know we're giving a patient medication, or if we're giving them a blood transfusion, we just go back to monitor and make sure they're not having an allergic reaction, or if it's, if their signs and symptoms have changed or progressed in a better way. I mean, it could go worse too, but that's just monitoring, keeping up with the patient.
So how do we know that those things are done?
Or documentation.
Documentation. Exactly.
Mhm.
Even like when they we'll talk about it, where JCO and some of these nonprofits and these regulatory agencies, they come in, they say, hey, this person came in with chest pain. Did this facility do everything? Did they follow the algorithm or follow whatever their process was for a person that comes in with these presenting symptoms? They go back, they pull out the rule book, their rule, and then they pull out the documentation. Does it match? Or if they have some things that do not match, that means they are not meeting the core measures. And another thing they're basing that on, they're trying to connect it to pay. They're also, I don't know if you've paid attention, like some of these hospitals or facilities they post their ratings. And so that generates those ratings for them as well. Okay, great. And here we go. Spin the wheel. Okay. Evidence-based practice. Gore, Francis, and Hurston. Evidence-based practice.
Akira had the
So, who had that one? Me?
Akira.
Oh, not here. Not here. Did you get to that one yet? Or no?
I had the patient-centered care and then
Okay.
Oh, I had
So,
evidence-based practice. I'm sorry, that was me.
ah,
I apologize. So evidence-based practice is I think it's based off of improved patient outcomes and improved quality care and consistency of care. I think with the improved patient outcomes, it's related to the situations where you're trying to prevent the patient from coming back multiple times for the same reason. So you're trying to improve whatever your care is and extended care afterwards so that they don't end up back in the hospital for the same reason
right.
related to that or um, other reasons as well, but mainly for so that they're not coming back constantly for a UTI. They're not coming back constantly for some type of infection that could be treated with like wound care showing up to someone's house or um, having the patient in a clean environment, making sure a nurse comes out and cleans a wound every other day or whatever the case may be. So um, that's kind of what I got from what evidence-based care is.
Mhm. Right. And also just making sure you have like the evidence, like research evidence for it. So like the what is it? The research behind it of what the experience was, the clinical experience was. So you're gonna have that too. Mhm.
Was there anything else from the group about the evidence?
Um, no, I think that's it. I mean, all they're doing is just improving patient decisions and patient, the decisions. Like if you think of patient relations, they're improving like the plan of care and the decisions that's the patient's care.
Maybe
So
they
no,
track maybe they track the evidence by um like showing the measurements of patients that did return or didn't return based off of a UTI or a wound infection. So, in 2025 it was 1,500, but in 2026 it was 1,000 because we've um have evidence that shows like if a nurse goes out and changes a patient's wound every 2 days, they have less of a risk of infection. Or if we discuss with a patient how To avoid getting UTIs, you need to drink more water. You need to have cranberry juice. You need to do this, that, and the third. And they follow those things because they understand based off of the education you provided for them. And it results in less people coming in for UTIs. I think that that's evidence based practice as well, related to evidence based practice.
Okay, so the evidence guides what we do. We're not haphazardly pulling things out of the air. The evidence has shown that, for example, a person needs to be turned, at a minimum of this time frame. At a minimum, a person, in order for a fever to go away, we need to give at least however much of Tylenol. The evidence, just like you do your papers, you go back and find evidence to support what you're saying. So the evidence guides what we're doing. We're not just haphazardly pulling things out of the air. It guides us. All right, teamwork and collaboration. Let's see, who did we have for that? Let me remove it here, and I got it over here on my little paper here. Teamwork and collaboration. Looks like I didn't assign it to anyone. So teamwork, we're on, like I said times before, everybody's coming to the nurse, but nevertheless, we're not the only one on that healthcare team. We have the healthcare provider, the dietitian, the person that actually delivers the trays. It could be the CNA. We have the social worker. We have the family members, all PT, OT, numerous people. And it's going to take us collaborating and not being in our own box, so to speak, in order for that patient to get the best care that they need. Remember that, we recall back that example that I gave. The patient needs to go, they want to get their hair done, had an appointment, they paid for the cosmetologist or the barber to be there. Also, that patient had physical therapy. That patient might have also had an appointment. So it was on us, but the person that works in the beauty shop only comes certain days of the week and times. It's on us to collaborate and coordinate that so the patient can get all of those things done, because it is important. This is important to get their, their manicures or their hair done, as also their physical therapy. Another example that we gave, the client was refusing to go to physical therapy because the family was coming and have a big birthday party or something on that day and time. While that therapist can alternate, every time, but can they see someone first or last? Ask the question, do someone want to swap the time? So it's going to take that continuous communication, open communication, the good, bad, and the ugly about the patient. The process is just to keep that patient care going. All right, let me spin the wheel here. And who will we have? Looks like it's going to be quality improvement. Alexander, Nichols, and Chappis.
I would say like just making improvements, of course, like reducing hospital admissions, making sure you're doing things in a timely manner, like not leaving a call light just dinging and ringing and making them wait forever when they need something, or making sure you get back on time with them, or communicating still.
Keeping track of like A1Cs or mammograms, certain testing that needs to be done yearly or bi-yearly, making sure the patient stays on top of their follow-ups and that they're following through with the appointments and that they're meeting all the guidelines. Communication between the specialty and the primary cares, things like that.
Guess with all that being said, just make sure those problems don't happen again. That's all I have.
Okay. All righty, we'll spin that wheel that last time, and it's informatics, and it's going to be Diaz, Lee, and Davis. Informatics. Tell us all about it.
It's more about managing patient information using the EMR system to document patient information. It will help to monitor like allergies or possible medication interactions.
It helps provide safe patient care. Um, hmm. You can use like the barcode scanning to help prevent medication errors.
So I guess it would be in a way of basically using like IV pumps. You scan someone's barcode to the IV pump, so you're not making as many dosage errors, or using the Omnicell, where people's medication is stored at. So having information being electronically given all the time, it can reduce errors. I'm not saying that that's not make mistakes, but it can reduce them down.
Okay. All righty. I think we've heard. Did I omit anyone? I didn't. It was not my intention that we hear from everybody. Anyone wanted to add anything about that? Okay. All righty. So we're gonna just go back and sum it up here. So patient-centered care, move this over here. This competency emphasizes recognizing the patient as the primary decision maker and providing care that respects their preferences and their values. Remember, they're the ones that's receiving the care. Yes, we have all these great interventions and things that we want to do for the patient, but we need to find out, what do they want? What do they understand about their disease process, the care, the injury, whatever it is that they have going on? And then what goals do they have? What would they like? And it's not to say that they don't want to or going to automatically refuse our interventions, but just making sure that they understand that we do have their best interest at heart. And part of that is by making them aware of the interventions so they can make an informed decision. And also, if they want to refuse, they can. So Nurse Bill states we need to be as functional as possible on this team. It takes teamwork and collaboration to ensure that we provide that individualized care needed for our clients. And even if we have 3 patients that have hypertension, we're still going to provide that individualized care, because still each patient is different. Their preferences are going to be different. This is a needed competency that focuses on effective functioning within nursing teams and with other healthcare professionals to ensure that optimal patient care, that best care is provided. Nurse Melissa adds, don't forget about the latest evidence-based practice, that is what she's saying. Melissa adds, this competency involves integrating the best available evidence with clinical expertise and patient preferences to guide that clinical decision. So we're not just pulling things out of the air, interventions out of the air. We're actually looking at the evidence that says, hey, this is appropriate for this patient in this similar or the same situation. So, and that guides our decision making. Those patient preferences add to us providing that going back that individualized care. Bill adds patient-centered care. This competency emphasizes recognizing the patient as the primary decision maker, like we just said. I had that repeated. They added me to the QI team. What is that? Nurse Melissa asked. Bill states QI, or either quality improvement. Now, a lot of facilities, you all do have, while you're onboarding to be that nurse, they do have that particular position. Some facilities have it solely. That's one thing that nurse does. And some of them have it as an added, so the nurse divides his time. I'm just saying this, but so that you can be thinking about it as you're going into your settings. Ask these questions. You have a QI team if it's what you're interested in. So the quality improvement emphasizes using data to monitor and improve care delivery processes and outcomes, looking at the number of falls, looking at the number of people that are on antibiotics, looking at the number of everything. And a lot of facilities with this, they actually look at every department, even environmental services, and see, how many soap dispensers are broken, how many, how often are we having to change, the dispenser. They look at all those things just so to ensure the whole thing is, we don't want people to lose life, limb, or eyesight. We don't want people to have infections just because of our process that we're doing. So the QI team looks at the finite details of all of our processes. Then Nurse Melissa added, yeah, they added me to informatics team. Of course, Bill's going to ask, what is that? Melissa states informatics involves using information and technology to communicate, to manage knowledge, and support clinical decision making. So our numbers say this. So therefore, it justifies why we need to do this. That's just an example. So as I'm reading through this, go back and look and see what you all jotted down for each of those, and just make sure that you can add or make adjustments to what you've written. We should always consider safety. This competency focuses on minimizing risk and preventing harm to both patients and the healthcare provider through systems, effectiveness, and individual performance. And like I said, it doesn't stop inside of that facility. It's till you make it to your next destination. Be thinking about it all the time. Weather, we're having all different types of weather, and weather can be cold extremes or heat extremes, storms. Safety could be, like I said, locking the doors, making sure that even during the daytime, whatever that process is for people to come in and visit, making sure that that process is being followed. Some facilities you have to show your ID. Some you just walk in and you touch a button, click a thing, or you have to actually sign in manually. But whatever that is, making sure that we're following that so that we all can be safe. Core measures are used to track how often hospitals provide recommended evidence-based care to patients with specific conditions. They help us to ensure that the patients are receiving that high quality standardized care based on the best available evidence. And how do they know? They look back and see what we've documented. So we have to take the time to make sure that we're documenting everything, because that's how they're going to justify or prove that we did all these things. And so let's want to pause. Right? Any questions about any of those concepts? We had, let me go back here. Patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, informatics, and core measures. Okay. So someone tell me, what do you recall about Oprah? The OBRA. What is that? What did it do? It's been around for a good little while. Oprah, OBRA. What did it do for us? Especially in some settings. So the next thing we're going to talk about is OBRA and also the PDSA cycle. And then we're going to talk about just those two things. So, all right. So what we're going to do is do another little short activity. We do need you to ensure that you're participating. If you have questions, you can actually send me a message or whatever if you are running to a roadblock. So we're going to switch up your groups again, but we're going to put you 3 slides that you're going to look at: OBRA and then the PDSA cycle. So again, I'm going to place it in your Canvas mail. Uh-oh. And then, so accept the invitation. We'll give you, it was 8 minutes, long enough to do that slide. We'll give you a few more because we do have 2 main topics, OBRA and then the PDSA cycle. So we'll probably give me like 10 minutes to discuss that. So what are we getting ready to do? We're going to the breakout room. Look in your Canvas mail. There are 1, 2, 3, 4 slides, but the topics are OBRA and the PDSA cycle. So discuss it and be ready to share out. It's still spinning, so give it a moment and hit refresh on your Canvas mail. So I'm opening up the rooms now. So go on over, look in your Canvas mail. All right, everyone should be back in about 45 seconds. And we will hear from you. Hmm. 20 seconds and we'll have everyone back. So we will hear from everyone again. It's not going to take us that long, but just to ensure that we have a good understanding of OBRA and PDSA. I'm going to hear from everybody. So I have everything listed on the wheel here and your names on the wheel. So you have a wheel, then you'll be told what's the expectation for you to discuss here. Both my little wheels cooperate here. All right, so here we go. Spinning the wheel. Let me share the screen. I was trying to put them on the same wheels, but it didn't work. So one wheel. So get ready. We'll hear from everyone. Okay. It looks like Miss Lampkin. And then you will tell us about, give us an example of PDSA.
PSA is plan it, study it, or plan, do, study, act. Or hold on one second. Okay, plan, do, study, act. An example we came up with is as like preventing patient falls. Like say like multiple patients are falling when they're trying to get out of bed without assistance. So the plan would be to like place a fall risk reminder sign outside their room and then also educate them on using a call light before getting up. And then the do would be to like try the new intervention on one hospital unit for like a week or two. And then the study would be like compare the number of patient falls before and after the intervention you came up with. And then the act would be if the falls, if there's like a decrease in patient falls, then you can continue the intervention and possibly move it throughout the hospital. But if the falls don't decrease, then you can just change the plan or come up with a new plan and then test it again.
Thank you. Looks like it's going to be on you, Miss Virginia. Let's spin the wheel. Okay, it's asking for an example of PDSA.
Okay. So, well, like she said, it's plan, do, study, and act. Um, one example. Um, Possibly a medication error if you grab the wrong medication, like say a shot instead of a Prevnar, you grabbed a Tdap and gave it to the patient. Um, Implementing better identifying the correct patient, going through your 7 rights for medication administration, making sure people are implementing it and paying attention to what they're doing and who they're with and what medication they have. And um, yeah, I don't know how else to explain that as a PDSA example other than just making sure they're implementing the um, rights for right medication.
That's it, you all. That's it. Good. So the fall example, the medication error example. That's why we have those processes in place. They're there for a reason. All righty, Miss Senora. Let's see what it's going to ask you to tell us all about. What is the D part of PDSA? What is the D? What does the D stand for? Uh-oh. Have I lost you all? Are you there? Hello.
Oh, the D would be the do. So the solution that you try the solution.
All righty. Let's keep it going. Hunt. Let's see. Tell us about Oprah. What is that?
It's still on me.
No, we're on Hunt.
It's the Omnibus Budget Reconciliation Act
Okay.
or the Federal Nursing Reform Act.
Just give us one piece of it because there's several little moving parts in it. Just give us one.
Um, okay, so we can do residents' rights. It just guarantees residents dignity, privacy, freedom from abuse, and the right to make personal choices.
Thank you. All right, we're moving right along. Y'all doing good. And is it Gore? Now, if I've left your name off, you let me know now because I want to share the love. Okay, Gore. Let's see what the wheel has for you. Okay, looks like it's gonna be the S. Tell us what's the S? What does it stand for?
That right there. So what is it? Plan to, ooh, girl, study. I think it is. It's not safety. So study. Is that right? Study. I think it's study. Let me look at my notes. Yes, it is. It's study. So it's basically the results. The results.
Is that your final
And
answer,
then
Miss
and
Gore?
then you said what?
Is that your final answer?
Yes, that is my yes. Yep. You look at the results. Yes, my final answer.
All righty. Well, we will toss it on to looks like Carter. Let's see what you're gonna have to talk about, Miss Carter. Let's see here. Do-do-do-do-do-do. Okay, we're back at Oprah. Just tell us another part of it.
Sorry, what'd you say? Tell us about what?
OBRA, Oprah, the act. Can you see the screen?
Okay.
You can.
Yes,
Okay.
it's just like freezing a little bit, so I just want to make sure I heard you right.
Yeah.
So OBRA stands for Omnibus Budget Reconciliation Act of 1987. It's specifically important in long-term care nursing. It was created to improve the quality of care and the quality of life for residents in nursing homes.
Okay. And just as we think about what that means, like what are all those processes and things that's required for in a nursing home that might not necessarily be required in a another setting. All right, so let's hear from you, Davis. Let's see what we're gonna have to talk about here. All right. What's the S part of SPDSA?
Study.
What does that mean?
Um, like a patient falling, you can like compare like the number of falls before and after. Starting like your rounds, your hourly rounds.
Yeah.
like studying the routine of your patients.
Thank you. Ms. Hairston. Let's see. The P. What does it stand for? PDSA.
It stands for plan. Um, like, so basically you're gonna identify the problem and then like you need to come up like with what you're gonna do to fix that problem.
Great. Let's see who we're tossing it to. Uh-oh. Francis. And tell us about, hopefully you're taking notes, you all, and you got it down to a science. Giving us an example of the PDSA cycle.
So PDSA cycle is, of course, what everybody said: plan, do, study, and act. An example is like improving medication barcode scanning. So you identify what the problem is, such as nurses not being consistent in scanning medications before administration. You develop a plan to improve medication administration compliance. The do, you implement the improvement like on a small scale, educating nurses, testing the new process um, in one unit. And then the study, review electronic health record data to determine whether barcode scanning compliance increased and medication errors decrease. And then the act, if the change was successful, implement it throughout the facility. If it was unsuccessful, modify the plan and repeat the PDSA cycle.
Got it. So we had false, medication error, and scanning. Another thing that came to mind was, is the equipment faulty? Is it because we usually use like that little scanner thing, and so is it the computer or is it the scanner? Because if we're not having, because usually those things are tied into pharmacy, it shows that we gave it, so it shows that that medication is empty, so they need to replace it. So if there's some disconnect, like what is the disconnect? So is it the user? Is it the equipment? And then the equipment, all the pieces of the equipment. So that was a good one. Great, thank you. All right, looks like it's on you, Lee. Let's see what we got. What is that A part?
The A is for act. So that means to actually act and initiate of what you've been planning out, putting everything that we've studied to the test in the hospitals or nursing homes or wherever you work at.
Thank you so much. So we're gonna have to know, hope you're getting it. We're gonna have to know what PDSA is in order to apply it to the scenario. So that's why we're spending the time with this. Okay, Alexander, let's see. Okay. VA, part of PDSA.
Pretty much like she said, the act. So if your plan works, then keep implementing it. And if it doesn't, then change it and test it again.
Okay, is what we're doing. The actions, interventions, all those words. Great, great, great. We're down to the last three. Here we go. Diaz. Looks like it's going to be. So what's the D part? PDSA.
So the D, it's for the do. So depending what the plan was, the
Mhm.
do is like to implement.
Got it. I think we only have one left on here. Do-do-do-do. Something else came to mind. So if I think we have Oprah left on here, let's see who's gonna get that. So I guess it's gonna be you, Nichols. So tell us about one of those other parts. I know it's how in long-term care facilities is how we provide that best care. What's another way? Like what is a piece of that? What do they do? And Shook, you can help too. You can just give one too. So I didn't have one in there for you. But Oprah, just tell us about a part of the Oprah. OBRA.
It protects patients' rights, requires the staff to develop an individual care plan for each resident. But I missed the question that you asked.
Just tell us something about OBRA. And then like you just gave an example, it mandates those individualized care plans. That's what it does. And then who was the last person? Shook, tell us something about OBRA, that act.
Um, I guess this one is more so like making sure like the nursing is getting their required training or like time and knowledge. Once you know you're in the nursing field, you have to keep up on it.
Is that your final answer?
Yes.
All righty. So let's pause for a break. Come back at it'd be 9:22 your time. Right? Yes. See you in 5. All right, come on back on. We're gonna go ahead and finish it on up. If you need to use a restroom or something, while we're actually reviewing these slides, just take the time to step away, put a message in the chat, because we're gonna go back and recap everything from last week and this week, and then we can push our time, all of the rest of our time, toward the end. So if you need to get up and move around a little bit, that's fine. Go ahead and do that, but just put it in the chat. Up, moving around, restroom, how you all have been doing it. All right, so let's finish up here. So we have the OBRA. You all said 1987. It reformed long-term care, nursing homes, LTCs. It required that comprehensive resident assessment, minimum data set. So this is where they pass out surveys, or paper or either electronic, and they give it to all the staff each shift. What is this person doing? How much care do they need? Do they walk in the corridor? Do they need setup help? Do they need two people? It's individualized, because it specifically indicates what this person needs. It looks at a time frame, usually like a 7-day time frame, and it has to be done every so often, at least every 3 months, unless they have a significant change. Now, this is also when you're going onboarding, ask, hey, do you have any openings on the MDS team? Most LTCs do have them. And there's an opportunity there for you to work as well, but you're going to be dealing with the data, giving surveys out to the staff, incorporating it. And from that, we create these individualized care plans. It also mandated increased staff training and quality assurance processes. OBRA encourages, not reduces, working together with that team. We talk about that teamwork and collaboration. It encourages that. So quality care benefits both the individual patients and the communities, because if our patients are better, more than likely they're going back to the communities. Therefore, the community will benefit as well. That person's back, able to complete the tasks that they've been doing in that community. For example, we had a farmer. They had to come to the LTC after they left the hospital for their rehab days. The community is dependent on that patient getting back well, and having those fresh fruits and vegetables available to them. So it benefits, excuse me, the patient and the communities. The focus is on achieving desired health, that optimal level, getting them back to their optimal level, their best, whatever they were taking care of themselves and independent prior to coming in, we want them back at that level. Individualized, you all have said that. Continuous education units or professional knowledge. Remember, it says we may have to retrain the staff. Requires adherence to the up-to-date professional standards. We might have done it like this for 20 years, but because of the evidence, it says we need to do it like this. More than likely, the policies and procedures for that facility will change as well. That professional knowledge. Nurse Melissa states, we use the PDS cycle during our informatics team meeting. Of course, Mike is going to ask, what is that? So we discussed it. We have the plan, the do, the study, and the act. So this process involves continuous learning and adjustment. You all gave some great examples. You all gave us falls, medication errors, and then scanning, barcode scanning. This process involves continuous learning, and adjustment is key to successful quality improvement, QI. Okay, so Nurse Melissa states we use the PDS cycle if the desired outcome isn't achieved in one of those cycles. The team should use the knowledge gained to modify their approach and start a new cycle. He told us about these 4 parts. Plan, identify the problem or improvement opportunity. Formulate a testable change, predict the outcomes, define the data, and collect the responsibilities. Implement the change. This is the do part on a small scale. I forget who said it. Hey, you do it on one unit and then see how it works out, and then domino effect to the next unit. Document those observations and collecting plan data. The study part, analyze the results and compare them with predictions. Identify what worked, what didn't, and then also why. Why did it not work? Okay, analyzing that data that's collected. That's the study part. Decide whether to adopt, to adapt it. Hybrid, we want to use this part because we saw this change, but the other part still needs to be worked out, so we can abandon that part. Okay, and like Melissa just said, don't forget. Let me go back to it. If the desired outcome isn't achieved one cycle, the team should use that knowledge gained to modify their approach and keep on going, do a whole nother cycle. So the team begins by identifying the problem. You gave some example: fall rates, complaints of responses, and that could be where the staff is complaining, not the staff, but the patient or family members are saying, "Hey, I pressed my call light, no one's coming," or it's taking an extended period of time, and this can be anything. And then planning a specific intervention for fall rates. Is it going to require us to round more often with, the patient's call light responses? Is it a delay? Is it a malfunctioning equipment? The do part, the intervention is implemented in a small, focused way, one shift only, one floor only, employees less than 6 months, employee greater than a year. These are just some examples of how we just do it in a small way. Data is collected and reviewed to determine if the change made a difference. ACT is based on the analysis. The intervention is either adopted more broadly, revised, or DC. Okay. Again, Nurse Melissa says we modify it and we start a new cycle. Okay, so we do have the Donovan model. It offers a structured, evidence-based approach to healthcare quality assessment. It helps stakeholders identify the strengths. It pinpoint areas for improvement and ensure that the care is both effective and patient-centered. Okay, get away from that, providing that individualized care, patient-centered. So structure refers to the context and resources in which care is delivered. This could be hospital, the clinics, the facility. And we're going to have some examples here on another slide. Equipment and technology, staff qualifications, the training, the organizational policies. The process part describes the actions and procedures taken during the healthcare delivery. This could be diagnosis, treatment, the preventative care. It could be patient education and communication, clinical workflows, and adherence to evidence-based guidelines. Process measures reflect whether care is being delivered as intended and can be assessed through medical records, patient interviews, or direct observations. So this is an additional task to you all that a nurse can actually do within a facility. They go around and ask these questions. Did your nurse introduce themselves? Did you see their name tag? Did you see them wash their hands? Did you see them use hand sanitizer? Actions taken in giving and receiving care. Implementing rounds as scheduled is a direct care activity performed by the staff. Was it done hourly? Was it done on every even hour? These are just some examples of the process part. So outcomes measure the results of healthcare on patients and populations. These can be clinical results, patient satisfaction in their experience, health-related quality of life. Outcomes are considered the most important indicators because they reflect the ultimate goal of healthcare, improving that health status. So what's this patient outcomes? This is just another way of looking at all of that summed up. I think I have 2 more visuals on it, but structure, process, and outcome. These are the examples here. So for the structure, we have the School of Nursing established a nurse-managed collaborative care clinic for non-insured patients with diabetes. 3 faculty members practice 2 days a week in this clinic. The process, an example of it is the RN case manager assists to find free low-cost medications to manage their diabetes. And then the outcome, what are these A1Cs doing? Are we having repeated readmissions to the hospital? So if the A1Cs are dropping and then we're not having those readmissions that are directly related to diabetes, then is what we did. Did it do any good or not? Okay. So Nurse Mike states Agency for Healthcare Research and Quality, AHRQ's mission is to improve healthcare quality and safety And that means that we're improving the patient care. They created this team steeps. So here we go. Let's see what Mike gonna tell us. So we have 6 parts. Safe ensures care avoids injury or harm to the patients, which is fundamental for quality care. Healthcare should not harm patients. A patient's coming in, for rehab, they're coming into the ER because of whatever, they should not be harmed, because they're coming in to receive care. They should not be receiving the wrong medications. It's not expected that they will fall, things like that. Timely. Patients shouldn't have to wait too long for care. So we want to look at reducing those delays in the patient receiving the care, because that in itself will reduce or prevent complications, and it improves outcomes, our timeliness. Effective focuses on evidence-based care proven to yield positive health results. Care should be based on the best medical knowledge that's coming from that evidence. So efficient avoids wasting resources, and that includes our time. The patients are paying for these supplies and things. Resources should be used widely to avoid waste. Equitable guarantees care quality is consistent regardless of race, pay status, or any of that. Care should be fair and accessible to all the patients. Patient-centered, that's that individualized care. We want to consider their preferences, their needs, and what they value. Care should be respectful of and responsive to the individual patient's preferences, needs, and values, you all. That keeps coming up. So this is just another way of looking at it. It's the same thing, safe, timely. And if you think about it, each step, it is what it is. Sometimes we have these acronyms and different steps, and it really, it doesn't lead you to what's really going on. But safe, we're trying to keep everybody safe, no injuries or anything. Efficient, we're trying to avoid waste. That includes our time. Equitable, and then patient-centered. We talked about that, learning what the patient's preferences are. Okay, so Team Steeps is a program designed to improve teamwork and communication in healthcare. Because we just said collaborating, those examples that we gave of the patients, the one needing their hair done, that same patient needs to be seen by the therapist, and they need to go out of the facility to be seen by, the nephrologist. So we are collaborating, working as a team, and communicating effectively about all of the good, the bad, and the ugly, so this client can still get all of those things done. Team Steeps aim to enhance patient safety through better team performance, and it does align with that AHRQ's mission, which is to improve healthcare quality and safety. So Nurse Melissa says quality and safety education is for nurses. This is this QSIN. Quality and safety education is for nurses. QSIN aims to prepare future nurses with quality and safety competencies. It defines essential knowledge, skills, and attitudes for nursing practice. It does have these 6 core competencies: patient-centered care, teamwork, collaboration. We keep hearing these same terms over and over: evidence-based, quality improvement, safety, and informatics. You all broke all those down and told us all about these. These competencies are designed to improve patient outcomes and healthcare quality. Okay, we talked about that. We're going to skip through that slide. We said as healthcare professionals, we are life learners. And so as a student nurse transitions to the role as a nurse, there will be a need for autonomy. You're going to have your own team. It's going to be you with decision-making and prioritization. So we're going to be putting it into work, really, because you're going to have your team of patients, who first, second, third. And then also, don't be afraid. If needed, seek verification from a more experienced, trusted colleague. We talked about professionalism last week. It involves being respectful, reliable, ethical, and accountable. It builds trust and promotes effective teamwork. Addressing issues respectfully and privately maintains dignity and promotes improvement without damaging that trust. We talked about that professional development plan. It is a continuous, intentional process aimed at improving one's practice, competence, and leadership. The nurse decides It is ongoing, self-directed learning and skill enhancement throughout one's nursing career. And so at a minimum, each year they'll ask you to, list these things that you hope to have gained, and they want you to come back and evaluate it, gain it, what was the barriers, and they want you to identify all of that. And then they want you to rate yourself. And then of course they'll rate you as well. So a personal development plan shows proactive engagement in professional growth. It allows for setting specific, those measurable goals for career advancement. This approach encourages self-reflection and continuous improvement. It demonstrates a long-term commitment to enhancing the professional competence. They have the new nurse program or novice, which is the new nurse, with preceptors, coaches, and didactic presentations. This helps new graduates develop that confidence, around their own autonomy in the decisions that they are making. And then after so long, you might actually transition to be a preceptor or coach for the next, the new nurses that are coming in. So we have regular unit-based in-service trainings. These provide consistent, targeted professional development. New equipment policy has been revised specifically on that unit. We get that information firsthand. These trainings often address current issues and skills relevant to that specific clinical area. Frequent engagement in learning activities reinforce knowledge and skills. The example about having a new equipment there, they'll have it so you can use it, touch it, feel it, and actually use it so that you can get the feel for it. Unit-based trainings allow for immediate application of new knowledge to practice. And then you're not having to go off-site to get this. They're actually coming to you on your unit. Okay, so shared governance improves quality of care. Just think about the words. It increases job satisfaction and promotes greater engagement and control over the nursing practice. Shared governance is viewed as an essential component of professional practice and is crucial for improving future healthcare systems. Even though they come to us all the time, but it's just not us, it's the patient and the others on the healthcare team. So successful implementation of shared governance model in nursing requires a foundation of collaborative councils at the unit, more than just the nurse, several nurses, PTOT. Clearly defined roles and responsibilities help staff understand their authority. What is it? Okay, I have this role. What is the expectation? Open and transparent communication systems, such as regular meetings. Usually, a lot of facilities have stand-up meetings at the beginning of their shifts. And at a minimum, and these things occur daily. So at a minimum, they may at least have that one meeting. If something's occurring, they may actually do a call meeting. And I say stand up, it didn't usually take that long. And then if you're one of those department heads, one of those leaders, then you may meet more often or after these regular meetings that they actually have. But this promotes trust, and it just helps with transparency. During those meetings, you tell the good, the bad, and the ugly, and then you bring out new ideas, especially if something of a process isn't working. Continuous education and leadership development for nurses support effective participation in governance activities. So go there, willing to participate, to share your ideas. And on the other hand, be willing to listen to others as well as they share their information as well. Just gonna pause right here. Are there any questions? Make sure we don't have any questions in the chat. Yeah. Okay. Any questions? I don't see any. We're going to keep going. I want to hear from you now. I want you to help me read through these slides. I'm going to read through this one. So need you all just to get ready to volunteer here. So shared governance includes participation, contribute to decision-making, and taking accountability for the practice. The nurse becomes aware of unit level practice, operational issues, and give them a voice in decision that affects their practice. This process supports empowerment, accountability, and professional growth. These are all key components of shared governance. So in those meetings that you're having, you're able to discuss everything, bring and then not only come up with share the problem, but hey, what it could be a solution. All right. So someone read this slide here. Specialty certification. Just volunteer.
Specialty certification validates expertise in a particular area of nursing. It demonstrates a commitment to maintaining high standards of practice. Certification often requires ongoing education, promoting continuous learning. Enhanced knowledge can lead to improved patient outcome and professional satisfaction. Sheesh. And credibility in the specialty.
Now, some facilities offer certifications within their facility, but then there are some national certifications as well. The National League of Nursing, you can look on there. There's all types of certifications. All right, so successful implementation of shared governance that we're doing now. It is nursing requires a foundation of collaborative councils at unit. We just said that. We want to clearly define roles and responsibilities. This helps staff understand their authority and their expectations. Continuous education and leadership development for nurses support effective participation in governance activities. I think I left off this right here on the other side. In contrast, a top-down management style and lack of administrative support contradict shared decision making. So top-down and lack of administration support is the opposite. That's not shared governance. That's not an example of it. So decentralized management in shared governance, the traditional hierarchical management style shifts to one where managers facilitate rather than control. So we're getting everybody's input rather than, it's just that manager and what they say. This in itself, it empowers the staff. We want to consider our work settings. This model creates an environment that enhances job satisfaction. We just said this, increases professionalism, and improves accountability among nursing staff. It actually gets that camaraderie going because people felt like that they're valued because they're listening to me. They might not have decided with the solution that I brought to the table, but at least they heard me. Collaborative relationship. Shared governance encourages nurses to work together and collectively develop these partnerships. Okay, someone read this one for me.
Shared decision making. This is the cornerstone of shared governance, allowing nurses to actively participate in policy and practice decisions.
Okay, thank you. Okay, so we actually, I think we worked our way through this one the last time. Okay, so we'll get into the pay part. Supported by tax money. We're going to get more into this here. Official government health agencies, primary service. We want to prevent disease. We want to promote health. If we can prevent an injury, a disease process, that's what we want to do. We do have local entities, we have state entities, and we have federal. And all of them pay or contribute to the services that their community members are actually receiving. Again, disease prevention, illness prevention, injury prevention. We want wellness. And so we do know that these are, remember, I don't know if you all remember last week when I said the different programs that the Well Woman program, the dietitian is actually not only just telling the people about nutritious diets that are specific to their diagnosis, hypertension, diabetes, they're actually preparing meals right there with the person. So that it's layering it up and it makes it more valuable to the individual. Not only they get a chance to taste, these items, because, we see all these recipes and things and we're like, how's that really taste? And so there could more that the potential for more buy-in because they're actually, so to speak, held hand in hand of how to prepare it. They're actually tasting it. So they are more apt to make those changes. So we're transitioning now to value-based purchasing, which is also linked to the facilities getting recuperated or the payback for the services that they have actually rendered. So it's value-based. And we'll talk a little bit more about that. But an example that stands off is, this facility, what is the rates of urinary tract infections? What is the fall rates? They're basing value on those numbers. So if those numbers are high, then there's less value considered in the care that that facility is actually providing. But the Centers for Medicare and Medicaid, they're linking their reimbursements to that. And I think the example that I gave you all was the patient comes in for, we'll just say, a heart attack or something that's unrelated, and they end up with a fall and a fracture. That fracture is not related to why they actually came in. What happens is they say, hey, we may or may not pay for those services. And you can provide the service. We want you to take care of the patient, but we might not reimburse you as a payer source because that's unrelated to, because things should have been in place so to prevent this person from falling, to prevent this person from getting the cubitus ulcer. OSHA looks at the workplace, prevents work-related injuries and illnesses. Equipment and things that are supposed to be in place, you all, if they're malfunctioning, broken, torn, we need to report that because we want to make sure that we're safe. The Centers for Disease Control, research data collection, they control, and this is a place where they have 2 hubs, but I think the main hub is over in Georgia. But you collect this information in the hopes of preventing widespread of diseases. So US FDA, assuring the safety and efficacy of foods, medication, and also medical devices. Okay. So we just talked about the value-based system. Private healthcare, these are like your Blue Cross Blue Shields. Services must be paid for. And so you can go into the urgent care, you know, with insurance, and then you still have to pay your copay. Go in urgent care without your insurance. You're going to have to pay for that visit before you pay, you know, before you actually receive those services. So, in private insurance, costs are passed on to the employers to the consumers through pricing of goods, meaning everyone indirectly pays for, you know, some part of that healthcare. It's not really free to anyone. It's not free at all, is what I'm trying to say. Someone is paying, some type of funds are coming from somewhere, whether that's a nonprofit, the federal government, or state government. So home health, that takes place in the house. We must have a skill to justify why we are actually there. Okay. So the ACA, the Affordable Care Act, initially intended to mandate Medicaid expansion nationwide. That was the intent. Hey, federal government's going to provide these funds to every state. They went through, they had a court case, and as a result of it, Medicaid expansions become optional for some states. That's why I recall me stating that you can go to this state and these people will tell you about all these resources that they have, and go to another state and they tell you about all their resources, but they're not the same resources. And so, because some states, of course, did have the money to provide the resource, and they would not accept the money to provide the resource for the people that live there. So you will not have, so with that being said, this decision has led to variations in Medicaid coverage across the country, with some states expanding eligibility while others have not. For whatever reason, the state couldn't pay the money to provide the resource, and then they decided to not receive the help from the federal government to provide those services to the people that live there. So skilled nursing, medically necessary care to improve health or maintain or slow decompensation. Think about a person after major surgery. What are they going to be needing? They might be needing finger sticks. They might be needing medications, wound care, things like that. All of those are skills. We said hospice and palliative care. Someone read hospice. What is hospice?
A
Excuse
goal
me,
to
Dr.
maintain
Ford.
comfort. Oh, never mind. Somebody's reading.
No, I'm gonna read it.
Oh,
Dr.
oh,
Ford, unfortunately, I have to leave a little early. I had a dental procedure today, and I'm having a little discomfort that is unbearable.
Okay.
So,
Take care.
all right, thank you.
You're welcome.
a goal to maintain comfort as death approaches, inpatient hospice care, home hospice care, and in terminal diagnosis.
Okay. Someone read palliative care. Hospice care is specific, is when that person has been deemed terminal 6 months or less. It doesn't mean that they really would not make it past the 6 months. I've seen people be on hospice. If they come off of it 2, 3 years later, you know, they're still around. But at that moment in time, based on the assessment findings, this is what they're deeming for that person. And comfort is the focus. Tell us about palliative care.
Maintain comfort at any stage in the disease process. It may start at any stage in the process. Client does not need to be terminal. Life-saving measures can be chosen.
Okay. So these are all different places that we provide care. There's even more than that. We wear so many hats. We wear different hats in the same setting. The possibilities are unlimited, you all, for us. So Medicare, we take care of our elderly. This coverage is also given to certain younger persons with disabilities that have end-stage renal disease. Generally, it's the person that's age 65 or older, but if a person also has end-stage renal disease, then they will also qualify to have Medicare. Now, if that person has low income, they may be dual eligible for Medicare and Medicaid, because we know Medicaid is based on the income. We did say Medicare has these 4 parts. This one right here, C is optional, is offered by a private company. So A is inpatient things that need to be provided. B is outpatient. D is for medications or prescriptions or drugs. C can include HMOs, PPOs. The person will pay for this. And this is where the person can have additional prescription drug coverage. That's that part C. But it's offered through a private company. We talked about the value-based programs. Urinary tract infections, falls, those are examples that come to mind. And where these payer sources, they look at and say, hey, you have great value, or you're not providing valuable care. The value-based program uses selected clinical processes of care, measures to assess hospital quality, and determine reimbursement. They'll get paid. They submit all these charges. Hey, the patient failed, they broke their leg, but they came in because they had a heart attack. It's not expected that a person comes in with pneumonia automatically falls. It's not expected that a person comes in with a heart attack that they're going to fall and break something. So urinary tract infection, just because a person had a Foley catheter inserted, that means that they're supposed to end up with the urinary tract infection. So Medigap, it is what it is. It stands in the gap. It assists with additional coverage for being able to pay for all the resources and services that the patient will actually receive. Medicaid, we say, is income based. So no income, low income. It's income based. That's Medicaid is going to be that main payer source for those services that are provided. We just say it's going to vary by state, because it depends on if that state receive those funds from the federal government in order to actually offer those services to their patients. This is a repeat slide. It's talking about how Medicaid was expanded. This one is too. I thought I had pulled those out. Okay, so the Centers for Medicaid and Medicare, the CMS, part of the United States Department of Health and Human Services, reimbursement. How is this hospital gonna get repaid for the services that they actually provided? We talked about the value-based programs. Medicaid, this one's a duplicate side as well. Income, no income or low income. Patients can be dual eligible. They can have, they can have a low income, so they'll be qualified for Medicaid, and they can be 65 and older, or have that disease process called end-stage renal disease. And there's another one that's on that list as well. CHIP. This is where the parents or the guardian of the child up to the age of 19 can't afford that traditional insurance, but then they make too much. Their income is not low enough to receive that Medicaid. So the child still receives their coverage. They can still go get their child checks. They can do all of those, get those preventative services. So it specifically targets children and families with incomes too high for Medicaid, but too low for that private coverage. So it takes care of the children. Federal government has put in funds to provide that services for the children. So they still get their well child checks, preventative services, immunizations, and all of that. Because there's just like a little gap there. Trying to make sure move us over here out of the way. So what do these options for insurances do for access to health care? So having all of these different options, you all, it allows people to get the care that they need. It's rare. It's very rare that someone didn't want to receive care and live in their best health, and so having all these different pay sources, it improves access to health care and improves health outcomes. Okay. So the National Quality Forum, a not-for-profit membership-based organization focused on meaningful quality measurement, is instrumental in advancing efforts to improve quality through performance measurement and public reporting. It has a central repository for healthcare measures that are considered scientifically sound and have been standardized for use across facilities and settings that's relevant to quality of care. A value-based quality of care. They're going back to that. So we talked about private insurance. So someone pays for it. It may not cost me anything, but someone is help offsetting that cost. So the uninsured, more than likely, they're going to be advanced. If they have a disease process going on, it's going to be advanced. And more than likely, they're going to receive that health care in a hospital setting because they can't turn you away because you don't have the funds. So the Affordable Care Act, so the whole point was to make healthcare more affordable. It decreased the number of uninsured people in the United States, so people could have the insurance, they could subscribe to it. It eliminated lifetime coverage limits. So in the event that a person has a disease process before the Affordable Care Act, there was a dollar amount. For example, a person that had a heart attack, we'll just say that they allowed $500. Everything related to the heart attack above $500, it fell back to the patient. So it eliminated those lifetime coverage limits. So there's no longer that $500 limit for someone that's had a heart attack. They can still receive all the services and their insurances are supposed to still help with that pay. It eliminated pre-existing penalties because you were penalized if you had a pre-existing disease process on your chart. You already had hypertension listed. The insurance companies would decide, hey, I do or do not want to pay for any services that's related to that. Okay, so we have MCOs, ACOs. These are all just payer sources for the care that people will receive. Healthcare providers and insurance companies share the financial responsibility for healthcare. Patients pay those monthly premiums and they're able to choose, there are different plans out there. And most people look at what disease process they have going on and then decide from there which of these plans that they actually want. So with the PPO, patients are allowed to choose from providers that are out of the network. So the whole purpose of all of these plans is to not limit a person from getting the care that they actually need and want. So managed care aim to improve care by coordinating services and promoting preventative care, like checkups and screenings. So you may have been on a job where they say, hey, the nurses are here today to do, little checkups on it. So like they'll do your finger stick and they'll see what your sugar is. They may run your lipid panel, things like that. They do those regular checkups and screenings, and that information is uploaded into your insurance database. And they see, they kind of sometimes they'll give you an incentive for going ahead and getting that done. If something's identified by that check, then you go on to your healthcare provider, share those results with them, and you get a head start on what's actually going on with you. So ACO is the same thing, just another way that we pay. Must have defined processes for promoting evidence-based medicine and reporting data to evaluate the quality and cost and coordination of care. All right, so someone read this one for me. ACOs, accountable care organizations. I'm trying to get us over here out the way. I'm gonna read this one.
Was somebody reading it? Okay, groups of healthcare providers that coordinate high quality, cost-effective care for Medicare patients, especially in primary care.
Ms. Nichols, was that you?
Yes.
Okay, just marking down. Yeah, because we have that professional thing that we say you participate and all that good stuff. I just want to make sure. All right, their goal is to improve outcomes while reducing unnecessary spending. They're saying, hey, why are we charging? Why is this patient on their bill? Why is it listed that we use 10 Foley catheters? What's going on here? Why is it listed that we use 5 band-aids? I'm just calling out supplies, but they look at that and just make sure that we're not wasting things. When they meet established benchmarks, they receive a share of Medicare savings. So these facilities, they aim to still provide that best care, but look at, hey, are we spending our money wisely? Why is it that we're using 9 Foley catheter kits on one patient? So is it that we need to go back and reteach our staff? Do we need to go back and have those unit-based trainings? What is really going on? So PPOs allow you to see out-of-network providers, but at a higher cost. And they won't stop you, but you more than likely going to have to pay something. So HMOs typically have a more limited network of providers and require that referral. PPOs usually offer a larger network and don't require referrals for specialists. HMOs often have lower premiums and out-of-pocket costs, but less flexibility. So they have all these different ways that we can still get care without limiting us from actually getting that care. Patients and clients should have enough information to make informed decisions, you all, about the healthcare services based on the quality, the reputation, and the cost. We want to make sure that they have that. We talked about QSIN already. We said the overall goal is to prepare the nursing student with the knowledge and skills and attitudes necessary to continuously improve quality and safety of healthcare systems. We talked about these 6 parts. QSIM, evidence-based practice, involves integration of 3 key elements: the best current evidence, the clinical expertise, and the client preference. We talked about can't get away from that. We can't rely on outdated traditions or informal advice without validated evidence. We can't just be pulling things out of the air. It has to have evidence as why we are doing it. We talked about shared governance, shared decision-making based on the principles of partnership, equity, accountability, and ownership at the point of service. Employee partnership is necessary for this shared governance. So we talked about that. And this is just saying, hey, what are we trending to? Do we want to remove the scope of practice barriers? Probably not. And if we do, we need to ensure that people are actually trained to do whatever it is. We are seeing these nurse residency programs. They already have the doctor residency programs, but we are seeing them trend to the same thing with nurses. So while you're in training, you're not only providing this best care under the supervision of a mentor, a preceptor, or a clinical instructor, but you're also receiving the funds and pay as well. How best evidence for practice guidelines is determined. So going back to that point, will they allow student nurses to apply for their nursing license prior to actually finishing that last class? That could lead to that. I haven't really looked into those nurse residency programs, but I know they're happening at some universities. So here it goes. Let's look at this PICO question, you all. Let's get to it. I think it's on the next slide here. This is just saying evidence-based. We have to have peer-reviewed scientific evidence for the decisions and the things that we're actually doing. We're not just pulling things out of air. Qualitative research. This is where we're gathering information from a lived experience. So we're interviewing people. They may be filling out a questionnaire. And then, so that's qualitative. Quantitative is some type of measurement information that we're getting. It could be heights and weights. It could be blood count, CBCs. It could be echocardiogram results, but there's some quantity there of the information that we're getting. So we have qualitative and quantitative. Okay. So we need to know about this PICO question, you all. Develop an answerable question A strategy that can be helpful in designing an answerable question in using the PICO or PCOT formula, which stands for population, intervention, excuse me, comparison, and outcome. And the T is time. Sometimes you don't see the T there. Search the literature. We have to have the evidence. What evidence supports what we're getting ready to do? We want to evaluate this evidence. What is this evidence telling us that we should be doing? Now, is this something that we can actually do? This just is another way of looking at it. The time, over what time period will this actually happen? What are these outcomes that we're looking for? Is there an alternative? Can we compare? So we implement projects, but then we also have that group of people that we give what we call the placebo. So randomized controlled trials are considered gold standard for determining cause and effect relationships in clinical interventions, evidence for clinical decision making. So this is just randomized. They're not picking certain people, it's just randomized. Okay, someone read this slide for me. Core measures.
Core measures are used to track how often hospitals provide recommended evidence-based care to patients with specific conditions. They help ensure that patients receive high-quality standardized care based on the best available evidence.
Okay. Those core measures, someone told us about that earlier. We have the Sentinel, the Cumulative Index to Nursing and Allied Health Literature. It specifically focuses on nursing, allied health content, biomedical, psychosocial aspects of healthcare, and it's designed for nursing and allied literature. I think you have access to this through your Canvas. All right, someone talk us through this health policy.
I got it. Relates to a health concern or issue and are meant to address a public policy goal. Policies result from a public decision-making process that directs the action or inaction of governments. Decisions are made by authorized government institutions such as legislators or courts, or by government authorized entities. Example, State Board of Nursing. The decision-making process is subject to public review and public input. Health policies address a public policy goal.
Thank you. I remember I told you all the Board of Nursing, most boards of nurses do have LPNs and RNs both on the board. So, and most of the time it's a volunteer position now, but nevertheless, you're there at the board at the table to help influence change, hopefully for the better for other nurses. And with that being said, that's just better outcomes for the patient and for the community. Someone read this Patient Self-Determination Act, and then someone else can read the Emergency Medical Treatment and Labor Act.
Requires healthcare facilities such as hospitals and nursing homes to provide patients with information related to their preferences for end-of-life care.
Okay, someone else read the EMTLA.
Enacted to prevent the denial of emergency service to patients, chiefly because they are uninsured and unable to pay for their care.
Okay. So we talked about the OBRA. We pretty much talked that through pretty good. The MDS, it gathers information so that those individualized care plans can be rendered. Those assessments are done at a minimum of every 3 to 4 months, or when there's a significant change with a patient. Then it gathers everything, finite details, how much care that this person actually needs. So health policy, state and national legislators are major public institutions. Legally, they're authorized to create health policies through democratic and constitutional processes. You know about all those different parts. While private insurance companies, accreditation bodies, and professional associations, they can also influence policy through lobbying and advocacy. So we have the FDA. We talked about it. Make sure our food our medications, and also products, medical devices that we're using are safe to be used. So the Health and Human Services, they're responsible for protecting the health and well-being of Americans and overseeing health initiatives. We just said what the FDA does. We said what the Centers for Medicare and Medicaid, we broke those down. Joint Commission sets standards for healthcare organizations and provides accreditation, promoting quality and safety in care. We mostly see Joint Commission come into the hospitals. But nevertheless, they're that regulatory agency. They're making sure, hey, we are doing what we're supposed to do in these facilities, following our policies and procedures, and that our policies and procedures matches the State Nurses Practice Act. It matches all those healthcare professionals that are in there, their scope of practice. HIPAA protects the patient's health information and ensures privacy and security in healthcare there. These agencies work together to establish guidelines that healthcare providers must follow, ultimately enhancing patient safety and their quality of care. You all, that's the whole reason for it. We want to provide that best care for our clients. We have Anderson, need to know, and the different parts of the model. Agenda setting, I think I have it spelled out over here again. Yeah. Policy formation, policy adoption, implementation, and evaluation. So someone read these first two, and then someone else reads these last two. Someone besides Senior, Carter, Hunt, Chappis, Nichols, and Francis. Someone else that have not read.
Anderson's model for policy creation follows a sequential process. It begins with agenda setting, where issues are identified and brought to public attention. This is followed by policy formulation, where potential solutions are developed. The third stage is policy adoption, where a specific course of action is chosen.
Okay, we need to know Anderson. We need to know them in the order that they're there. And it kind of mimics a nursing process. Okay, someone else read those last two bullets and move us over
Dr.
here.
Ford, you didn't say my name because I did read.
Gore,
You
you
said-
did read. I sure did. I didn't mark you down, Gore. But you read again for me. Right here, the
Okay,
last two
that's
bullets.
fine. Yep.
Thank you.
Next comes policy implementation, where the chosen policy is put into practice. Finally, policy evaluation occurs to assess the effectiveness of the implement policy. Understanding the sequence is critical for nursing to effectively participate and influence health policy at various stages.
Need to know the order. Got to know the order. Okay. Maintain your currency within your practice. Read widely and critically. Professional, accountable nurses keep abreast of their practice by reading journals, joining professional organizations. And those, a lot of people just subscribe to whatever that journal is for your setting that you're working in. And a lot of facilities go ahead and prescribe and subscribe to them as well. So you have access to those because it's going to tell you the latest things that are going on within that setting. Attending professional conferences, participating actually in nursing research, that helps to keep us abreast on what is going on. We talked about those. That's why these are duplicate. We already talked about these. And you all did good with going to your groups and reporting back out. You all rock with that. Yep, you told us about informatics. The National League of Nursing aims to lead in setting standards. These are things, this is the norm. These standards are considered the expectation. These goals applies to all levels of nursing. There's an expectation, and the expectations are called standards. The National League of Nursing, they set these standards. They're the ones also to, well, your boards of nursing, they're the ones that decide like your seat time, how long you need to be in this class, and so forth and so forth. We talked about QSIN already. This is a duplicate slide. Talked about JACO, Joint Commission, coming in, making sure that our processes are correct. They're not for profit organization, but it conducts on-site surveys. They usually, for the most part, if they're coming for like a regular visit, they'll let you know when they're coming. For the most part, any of these regulatory agencies can pop up anytime. But the whole thing is they want to make sure that we are providing the care that we need so we can keep people safe, keep ourselves safe, and so forth. All right. Any questions about any of the concepts that we have covered? So I'll stick around if we have questions about anything, any to talk.